session, we'll really start to focus on putting this information to action and specifically how organizations are using technology, data, and workflow to essentially achieve successful attribution and activation models with their patients. I'll move through. I think you've gotten to know us rather well. But we are starting to round out our time together. There are 3 more sessions, including today. And today will be largely focused, as I mentioned, on technology and data. Our next session in 2 weeks will focus on patient communication and its role in the attribution and activation process. And then week 6 is our report out, essentially, of our group projects, which we will be assigning today. And I don't want people to panic. We don't think it's going to be a exhaustive or time-consuming exercise, just an opportunity to reflect back and work, within your own organization, but then share with your peers to essentially assist them in understanding kind of how you're going to apply this information in your own practice. Today, we're going to quickly go through your feedback from the past session and talk a little bit about your answers to the homework questions. We are going to then talk specifically about the attribution, technology, data, and workflow processes, and then a little bit about the activation, technology, data, and workflow processes, which will really set up next session's conversation, which gets into patient communication styles and tactics. We will have a discussion around some general data skills that support the type of work that needs to be done, really help you understand what type of human resources and skill sets are necessary to make this happen. And we do have a couple of discussion questions ahead of session 5. And in that assignment of homework for session 5, I'll also be taking you through and discussing the group assignment. As I hope many of you have done, we have made ourselves available in half-hour windows for the purpose of doing a little one-on-one consultation about the group assignment, about the project that you'll be doing. Again, as you'll see, it's not we don't want anyone thinking that this is going to be a very time-consuming exercise. It's really just about reflecting upon what we've discussed here. We asked you in the homework, what technology systems do you have today to support the attribution process? And we've gotten, essentially the answer that I think runs the kind of gamut that we see pretty typically in the safety net. Some folks have invested in human resources that can assist in this work, specifically data analysts or programmers or, folks that really understand how to manipulate large data sets and produce information necessary to support those processes. Still, some others are really doing that with, a series of desktop-type tools, which can include Microsoft Excel or other spreadsheet processing systems. And some folks have essentially acquired and used, their EHR or practice management systems, which, are able to be, essentially used to make this happen. As we're going to talk about today, organizations are fairly rapidly exploring systems that go beyond essentially the capabilities of the EHR and practice management system. And we will talk about, essentially the concept of a population health management tool. And even within that definition, there's kind of a wide variation in what that actually means, essentially in terms of what capabilities a system like that would bring to the table. So we'll be discussing all of this today as we go through, but this is kind of the information that you provided us with about what you're doing. We did ask as well, what skills and systems would make you feel better prepared? And I really like the answers. I think that this really kind of gets at the pace and the frequency at which we will be expected to interact with large data sets that says, we're going to need to automate some of this stuff. It's going to have to just happen. It's going to have to be highly efficient and effective and really just get information into the hands of people that need it. And that's absolutely consistent with our findings in terms of working with our clients. folks are starting to feel like, now that you've got this data, there's truly kind of a new role or responsibility within the organization for putting it to use. So the ability to conduct the kind of outreach and essentially proactive care management on behalf of these patients really is a separate job function that is growing, and it's growing in need. And right behind that, but maybe not as fast, is it's growing in interest in terms of payers directly supporting that work. So it's not it's not just a part of what you're expected to do in terms of billing the patient for the face-to-face encounter or the time that you spend with them when they're in your building, but finding models to directly pay for those types of services. And then the last feedback was, better ways to measure and report on the outcomes themselves. And of course, that's a significant challenge, and also one that we see a ton of growth, in the way that we're going to be asked to perform. Not all of the groups represented, and in fact, I'm not sure which of the groups may be exposed to things like MACRA, but MACRA is a fairly significant move in the direction of reporting and performance being a part of really all Medicare payment. Again, Medicare may not be our primary or largest payer source, but it's so influential in terms of how the market moves. And whether our organization, because the FQHCs are definitely excluded from it and others within the safety net may be excluded from it, it's still going to move the market, and it's going to continue to put that pressure on our ability to report outcomes, explain our outcomes, and of course, what comes along with that, of course, is the need to improve. Any additional comments on those first two questions before I move ahead? Okay, we'll keep moving. We asked what processes does your organization use to accomplish the patient outreach function? And again, fairly consistent answers with what we've seen in the in the safety net as general trends, medical assistants, care managers, social workers. And really liked this answer, pharmacists, because we're seeing, and I know Amanda's on the phone and I'm sure is smiling because she's a big proponent of clinical pharmacy playing a role in the care management process. And really seeing that these are folks that are really well equipped, and in some cases even better equipped than our billable clinicians themselves in making this happen and work. We have a group reported that they're involved in a pilot program whereby they're targeting and reaching out to 10 new high-risk patients every month. On top of course, the kind of standard care management around chronic diseases. And a third group having, kind of a geographic location where they're able to reach to those folks because they're kind of co-located with the senior wellness center, but just physically taking the time and the people to be present with those patients and make sure that they understand and are addressing the kind of the holistic needs of that population. We asked how the outreach process could be modified to support, by way of using the attribution data processes. And again, really good answers, really consistent, identifying more readily the high utilizers, really to kind of prioritize our care management resources and capabilities. Also looking for folks who are kind of falling off of the radar, essentially. They haven't, we were with a client early last week who said, we kind of measure the quality of our care by how long it's been since we've put eyes on a particular person or a patient. That was in a very high acuity environment where, high acuity mental health environment where patients had a likelihood to decompensate if they did not have, essentially their caregivers' support on a more regular basis. So they would actually track how frequently do we have eyes on this person? Is someone from the organization seeing this person, whether it's in the clinical setting or even in the community and in the street, on the streets. Another group said that if they were to engage in an attribution process, they would need care coordinators to help connect and maintain contact with that attributed population. And this is the overwhelming trend in both care team redesign and, of course, payment methodology change. We're already seeing in, of course, Medicare, which, as we just mentioned, is super influential in other places, the addition of billing codes that support this. Because once you have the data, there's just a lot of work that can be done to help keep populations healthy. And getting your patients paired with folks who know a lot about them because they're kind of privy to their care plan and their self-directed goals, but can also reinforce and support them can be highly impactful. And of course, again, the group that's working with, to really kind of up their game by kind of adding 10 patients a month to this kind of intensive care coordination process. Any final thoughts? Questions? Okay. Let's move ahead. And you can chat questions too if that's, if that's an easier way for you to kind of ask your question. So I want to talk about how we're going to look at today's content. So it's in our experience, part of the reason why it's taken so long for us to really transform the system and shift to a value-based reimbursement environment is because of kind of a classic chicken and egg problem. It's really hard to make the significant investments in both the technology, the data systems, the people, and the underlying processes when there's no payment methodology for it. But it's hard to justify a payment methodology without putting those pieces in place. So since we know that not everyone on the call is going to be essentially at the same starting point, we wanted to put some kind of hypothetical parameters around our discussion today. We want you to assume that we are working in an environment in which we have the opportunity to earn considerable bonus payments tied to the achievement of a set of clinical and financial outcomes. Some of these outcomes will specifically be focused on improvements in the cost of the highest risk population patients. So it's not good enough for us to just improve things like chronic disease management, quality indicators. We also have to reduce costs for the high risk population. And these outcomes are measured by Medicaid, not by your self-reporting, which means they are measured for the entire population that they attribute to you, whether you have ever seen them or not. And these are a couple of key components to take into consideration as we look through the lens of attribution, because what the overwhelming ask of the safety net, and really of all providers, is don't just do a good job with the patients who are actively engaged with your organization. Do a good job getting patients actively engaged in your organization and then keeping them healthier as a result. So it's really, we've begun to move past a point where, removing patients from our roster is the primary go-to strategy, nor am I suggesting that that's what we've intentionally done, but we've historically focused our quality and outcome measurement on those patients who actively engage. We have things in our quality measures that say, for patients that have been seen twice in a 12-month period, how did you perform? And we're shifting to a world where we're saying, if a patient's in your geographic catchment area and Medicaid wishes for them to essentially be assigned to your organization, it is becoming increasingly important for you to be the one that has the tools and the techniques to get that person into the building, even if they are resistant to care. And we're going to talk about the fact that there are still important opportunities to have a patient removed from a panel, but it's not really essentially what we're being asked to do. We're being asked to manage them. So with that in mind, our challenge is, how does our organization improve key population health outcomes from a group of people who may or may not be effectively engaged in improving their own care? And the best available strategy is really by understanding who the attributed people are and activating them to be more proactive in utilizing the healthcare system effectively. We are seen as the safety net as really kind of the first line of support for that. And there's a huge opportunity, we believe, financially, in terms of additional investments in the safety net if our safety net organizations are seen as leading the charge to accomplish this goal. So there's a huge burden then on our technology, data, and processes essentially to make that happen. So I want to talk about 5 very specific attribution-related workflows and talk about the underlying processes and then the data necessary as well as the technology to support making these processes work. So the 5 processes, and there's probably a bunch more. There certainly are other things that we see groups do that are effective, but these 5 really kind of distill down to the most important and most commonly seen processes in this world of value-based reimbursement and the need for attribution as a result. The 5 are essentially the ability to perform a data comparison between the attributed and seen population, which we'll define a little more clearly for you in a second, the ability to risk stratify a population, the ability to conduct medical home empanelment processes, and supporting targeted outreach, the proactive scheduling of patients, and the documentation of the results of the care coordination process. And lastly, as I mentioned, the removal from attribution when either possible or warranted. And we'll talk about scenarios where that is warranted. So let's start with attributed versus seen. And I actually want to start with just a quick, anecdote about this. One of the early forming networks of health centers that we worked with entered into some very good contracts in their Medicaid managed care environment that really got to the point of aligning essentially their interests with the interests of their payers. And what I mean by that is enhanced reimbursement for larger care teams to support clinicians in managing patients to better population health outcomes. And they spent, essentially a whole year implementing a set of processes that allowed them to track and report and pinpoint patients that had enhanced needs and really start working down the list of the most complex patients. The challenge, though, was that their only reporting system that supported them in this process was their electronic health record, and as a result, they had a fairly substantial portion of their population that had not been seen but had been attributed. And the difference between the performance when patients came to the clinic clinics and when patients did not were dramatic. The patients who came to the clinics had generally good health outcomes, at least in terms of process measures. So they were doing evidence-based medicine very well. They did not have a systematic process, however, for addressing the patients who were not proactively reaching them and reaching the clinic. And that distinct difference, or that very difference, was what caused them to miss the overwhelming majority of their performance bonuses, because when the payer was looking at the data, they were seeing large gaps in care. And when the provider was looking at the data, they were not seeing large gaps in care, but they weren't working on a comprehensive data set. And so it can be literally that simple and that impactful in terms of how this attributed but not seen population can have on our results and on our financial outcomes for our organization. To do this right, you really need to integrate data on the population that your organization is expected to manage as compared to the population that you have a historical relationship with. And we do this with attribution reports from the payers, which should include either enrollment information, demographics information, detailed claims data, or the like. And we need to match that up and have the technological capability of matching that up with our kept appointments and our health status and care plan data, which resides in our EHR. And this was the gap, essentially, that organization, which is a real organization that's been doing this work now for the better part of 5 years in a very systematic way, because they learned early that not doing this was, led them to bad financial outcomes. Typically, the organizations have chosen to do this in a variety of different ways. And I think you guys did a nice job of kind of echoing this in how you answered our homework questions. Some have tried to accomplish this by basically staffing or better staffing essentially a data analyst function, someone that can pull the necessary data sets together and then produce the necessary reports. And the goal is to essentially work down this list, and in each increasing period have fewer patients essentially in this attributed to us but not yet seen category. Others are bulking up essentially the ability of their EHRs and practice management systems to support them in this process. So it's really important that you're kind of using both the EHR and an external data source like a patient attribution report from the payer. But what some folks are doing is directly creating charts, if you will, for the patients who have not yet been seen, and then beginning to record information they have about those patients even before they enter into the organization. So if they get detailed claims data, they would know essentially a problem list of diagnoses for the patient, and they could start to, using their EHR, identify patients who are already, visibly kind of higher risk based on, the little bit of information they might have. We've also seen groups implement in the EHR a telephone screening process. So when a patient gets attributed or assigned, and if they get the telephone number from it's a big if they get the telephone number from the insurer, and even bigger if the telephone number works consistently, but if they are able to reach those folks, that they are beginning with some health screening tools built directly into the EHR that are already helping them kind of prioritize. And then, of course, there's this emerging class of population health management software that's really designed very specifically to meet this particular need. It's software that is used really specifically to track the health status of a population of patients that may or may not be seen, but are attributed by the payer. And those systems are essentially data aggregation tools that can take data sources like electronic health record, like practice management system, but also like hospital discharge information, admit discharge information, and payer claims data, and really piece together one unified picture of a patient, even if that patient has not yet been seen in practice and using the EHR. So certainly an emerging class of software. We're not going to get into individual products on the market. That's not our, that's not really our role. But this is an emerging class. And just like I would say electronic health record systems 10 or 15 years ago, the definition of what it is and how to use it, I think, is a little murkier, whereas EHRs, I think we've come a long way in terms of having fairly consistent, given meaningful use and given some other initiatives, fairly consistent idea of how it works, what features are supposed to be in scope. With the population health management system, we still see a little bit wider variation, just frankly because they are relatively new tools and systems. The next step in the process is the ability to risk stratify the population of patients. So it's the ability to assign a relative score of risk to an individual patient so that resources can be allocated efficiently across that population. Remember, we said that the goal was to achieve a certain set of health outcomes, including the reduction of cost in a high-risk population of Medicaid patients, with fairly substantial bonus payments on the line if we are successful in doing that. And so the ability to risk stratify helps us identify where to place our care coordination resources to best achieve that goal of improved outcomes and reduced costs. So to do this, we need a variety of data sets, very similar to the attribution data sets, that include the list of attributed patients, claims data, if available. EHR data is highly desirable to this process because that's the clinical status and the clinical planning. And then social determinants of health data, if not available in the EHR. The jury's kind of still out. Many organizations are building this directly into their EHR. We tend to feel that that's probably the right path, but in some cases that might be data that's collected by a plan. In other cases, that might be data that's collected by partner agencies that actually are, working on those types of issues. Area agencies on aging, for example, other programs affiliated with or supported by United Way may have information on these folks that could be useful to this kind of risk stratification process. There's three different ways that we're seeing organizations tackle this risk stratification process and program, if you will. I'm going to take you quickly kind of through them, and we'll give a little bit of commentary because we are actually also simultaneous to this learning collaborative. We are in fact also conducting a learning collaborative on risk stratification, and the findings there have actually been, I think, rather enlightening, and I think we're starting to make some headway on this challenge and on this topic. The three ways that we're seeing organizations tackle this problem: one is very simply using a risk score from a payer. So if every payer uses some type of risk adjustment process and risk scoring process, and we can kind of tap into that. The second way is to purchase or adopt a commercial risk scoring algorithm. So oftentimes, if you buy a population health management system, one of the features of that system will be that it comes with some options for risk scoring, or you can purchase special software, and so the algorithm kind of there's like a level of secretness to the algorithms because they're commercial software, but it can run the data and it can spit out relative risk scores. And the third option is to create a risk scoring algorithm yourself, and we'll talk a little bit about kind of how that might work and what that might look like. So, using a payer's risk score, and we're going to do a little pro and con discussion here. Is on the plus side is a low-cost option, meaning the plan has already paid for it. They have already done the work to crunch the numbers. If you can negotiate with them and get them simply to share that with you, it does provide you with some information to assist you in resource allocation challenge in the population health world. As a result, it can be relatively easy to implement. There's nothing really for you to do. Except accept that number. I guess the hardest part, I would say, of risk of getting and maintaining a risk score from a payer is actually negotiating to get that information in their file, in their attribution files that they send to you. Another advantage is that these are models that tend to be considered highly statistically significant. There's been a lot of investment made in these risk adjustment models, and as a result, they tend to have some real validity, and the payers have expertise in applying their risk scores, so you can be assured that they have applied them well. They have a vested interest in doing this right because it actually influences how much money they get paid to manage these patients. So they've spent a lot of time implementing these and making them work. I guess I would add one other advantage that I think we've kind of uncovered as we've worked with the group on risk stratification and risk adjustment is that the plans will often base payment methodologies using the risk scores that they have assigned. So when I said in our opener, you have an incentive for managing a high-risk group of populations, it's typically going to be the plan that determines who that high-risk population is. So aligning with the plan scores can be useful from that very standpoint, that it actually allows you to focus on what the plans think you need to focus on. On the downside, payer risk scores are really developed exclusively for the prediction of cost. That's their function. And because they're meant to be predictive of cost, they often don't necessarily take into consideration things like will the patient be sensitive to care coordination? Are the patients relatively activated and invested in their own care, which are fairly critical in making a decision about resource allocation and use. So, we like to say that while directionally correct, a payer's risk score is never really going to be designed specifically to support a care coordination model. They also historically, this is changing, but historically have been almost exclusively driven by diagnosis code. So they do not really have the ability to factor in social determinants of health. And lastly, one of the things that can be very frustrating for folks, certainly folks that are operating in managed care environments with a lot of plans, is that each plan will have a different philosophy on how they do this, and it can be really frustrating because when you're allocating your care coordination resources, you're trying not to allocate them differently by plan. It's really challenging to do an apples-to-apples comparison of two different risk scores, and so it's forced providers to kind of set up multiple processes, a different process essentially for a different plan, and that can create some inequities, but also just some frustration and unnecessary work. So some organizations say, you know what, I'd rather have one model. I'd rather have that one model applied to my full population, and I don't necessarily want to be the one to build that model. I want to take something off the shelf, and the adoption of a commercial algorithm, either through the purchase of a population health management tool, or finding a vendor that can come in and just crunch numbers for you and provide you with that analysis, is one way to go. It of course creates greater control and flexibility. You can look at different models and options. You can look at models that have more heavily weight things like social determinants of health if you feel that that's important to your population of patients, which you probably do. And so you have better control and flexibility. You can also then apply it to all payers for consistency, as I mentioned. There are a lot of different options for data sources, kind of getting back to that control and flexibility, and may include approaches. These models may include actually some of the algorithms then for how do you manage the various populations. So, a population health management system won't just tell you, here's your riskiest patients, but will also start leading you down the path of, and here are some of the things that could be done to minimize essentially that risk. On the downside, these programs and systems are expensive, and they're proprietary. They're proprietary for a reason. It's to defend that expense. And so you're not buying into kind of an open understanding of how the risk assignment is done, so much as you're buying into essentially them conducting that risk evaluation for you. So you may get a result, or you will get a result, but you may not understand the underlying model and the factors that went into driving that result. We're not seeing many organizations do this at this current point. But we are seeing, I think, more uptake of this approach as they are starting to implement population health management tools on top of their EHR. So that's where we'll see a growth in this model. And this should say number 3, but using your own method is inexpensive. It's based on your experience with your patients. So, you get your clinicians, you get some folks with a lot of experience, some of the medical assistants or care coordinators in the room, and you say, what are the things that we see in our population that are aligned with heavy utilization of the system and poor outcomes? And I think most teams that have spent a lot of time working with a specific population can pretty readily come up with some of the clear kind of markers of high risk. This can be much better aligned with your workflow, and is based on your available data. So buying a commercial algorithm that's heavily dependent on having claims data when you may not have claims data is probably not a winning proposition. So in this model, we see a lot of groups starting somewhat slower and really building, based on the data they have today, and also working on developing some data sets that they don't have. Obviously, the downside here is, unlike those other models that are, people can point to and say they have statistical significance and there's highly validated across millions and millions of patients, that's not so much the case here. It also requires a fair amount of technical sophistication, and one of our early findings in working with the group on risk stratification is oftentimes EHR data in particular was not really designed necessarily to drive risk models. I'll give an example in a second. And so what they're finding is they don't have necessarily the data that they really need or want to drive these models. The example that I'll give you that we run into a lot is a lot of the organizations that we've worked with have said, look, family and social support is a huge indicator for us of whether the patient's going to have good health outcomes or bad health outcomes. Essentially, the ability to implement one's self-directed treatment plan is often heavily influenced by whether the patient has family and social supports for doing just that. In many of the EHR systems that we've seen, the whole concept of family and family medical history and the like is addressed in a very different way than simply answering the question, what is the level of family and social support available to this patient? And so it's hard to run a analysis against a data set that's either imprecise, incomplete, or frankly doesn't exist. And that's probably been the biggest challenge that we've seen in working with groups on risk stratification. And lastly, may not have the external validity that other folks might wish. Where that really hits the road, just so folks understand, is getting your payer to work off of your risk model can be a challenge because they feel like they've invested so much time, money, and energy in their risk model. So it can be challenging, essentially, and we will leave this concept by saying we're not suggesting that there's any one right thing to do between these three. But what we are finding is that the groups that are making, I think, the most immediate impact tend to be the ones that are using this method, where they're just getting started. For lack of all the data they need, for lack of an expensive population health management system, they're just getting started risk stratifying their population. I'm going to stop for a second. I haven't gotten any questions via chat, but we've thrown a lot of information out of you in just those first two. I wanted to see if there were questions or comments, and before I move on, and of course, if not, we'll just move forward. But I thought it'd be a good time to pause for a second. Okay. The third process that needs to be supported, and I guess I was wrong. I said that should have been a number 3. It, in fact, should have been a number 2 on the last slide, because number 3 is medical home empowerment. Medical home empowerment is the linking of a patient to a caregiver or care team who will have accountability for the creation and execution of that patient's care plan. That's probably a huge simplification, and we know probably every single person on the phone has spent the last 5 years at some level or another kind of decrypting this medical home thing and implementing it and the like. But we feel that this is pretty much where the rubber is going to hit the road on population health management and essentially our value-based reimbursement systems that we're likely to see increasingly over the next several years. The process of medical home empanelment is really how you, as the leaders of an organization, take the external challenge of managing to a population health outcome and divvy it up amongst the care teams in your organization. And so, again, this is a process that really, again, relies heavily on the current assignments, which are how your patients are currently assigned. And if your patients aren't currently assigned, we're going to talk about a process to get them assigned. The attributed population from your payers, the risk scores, if available, and then and panel sizes or targets for your population. We did have a question come into the chat window, so I wanted to address it. What is the best way to get access to the payer reports where risk stratification already exists? In our experience, the single best way to get access to patient reports that have a relative risk score is simply to ask for it. And the best way to ask for it is to someone within the payer organization in kind of a provider relations function, and with a commitment that you intend to do something meaningful with the data. We have not seen a lot of payers who are hesitant to help prioritize the patients where you can help save them money if you articulate a plan for what you're going to do with it. So take this presentation, show them that you intend to attribute, risk stratify, and then empanel, and then care coordinate the patients, and you want to do that with a top-down approach from the highest risk to the lowest risk, because that's where you're going to get the best outcomes for the patients and ultimately for those plans. So again, it's just kind of being prepared to answer the question, what are you going to do with this information? And generally speaking, plans will share it. There's a flip side to this answer, which is don't sign up for a value-based reimbursement model without getting some type of risk data from your health plans, because, and that includes Medicaid if you're in a fee-for-service model with your Medicaid agency. So you shouldn't be contracting essentially for risk without getting some of that. Even if you ultimately decide that you want to do some of your own risk stratification because you feel that it's more sensitive to things that are predictive of the patient's outcomes and cost, there's no reason to not have the plan's risk scores as well. And frankly, it's good to do some evaluation of whether their risk scores and your identification of your high-risk patients are overlapping. You would hope that there would be, because like we said, it should be directionally challenging. So that's certainly about as deep I think I can go as an answer in this forum. I think it does get to kind of negotiation tactics. As you're discussing taking on more risk, there should always be essentially more transparent data sharing, and there are kind of some specific tactics within how that works. Meaning, if you're looking at a really risky model, the list of things that you need gets increasingly longer than if you're just looking at kind of a pay-for-performance, upside-only bonus model. Usually, the plans will push back on giving you too much data to drive simpler, less risky models. We want to talk a little bit about the empanelment processes. Some facilities choose to assign patients to a caregiver or care team before they've been seen. Others only do so once they have been seen, and they maintain a corresponding kind of centralized function for managing those patients. If you've never had an empanelment process before, some organizations use what we call the 4-cut method, which we'll describe in a second, to kind of do a rapid initial assignment approach of those patients. So we'll look at the 4-cut method so that you can kind of understand how it works. And different options exist for determining panel size. Many methods for determining panel size have historically been based on average number of visits per year. In a population health environment, we're not sure that's the best approach. We certainly understand why that approach has worked to date, certainly in the safety net, environment. And we want to just caution that we think that those models are going to evolve more towards risk-adjusted kind of panel sizes that are not linked exclusively to the provider, but to that broader care team. So when we talk about kind of the healthier preventive services population, they may be managed really more telephonically than we've seen before, and that might essentially grow panel size on a per provider basis, but without but by adding other members to the care team. I want to talk quickly about the 4-cut method, because if you're in a situation where you haven't done any sort of kind of internal empanelment, and by the way, this is the medical home tends to be a very primary care driven process, and we know that that not all of you are essentially based on a primary care model, but we've seen this now implemented in specialty care. We've seen this implemented in mental health care. I think the mental health medical home is a very real concept. I'm sure some of you are familiar with, and we are even seeing this type of approach used in acute care settings where there are going to be outcomes tied to, payment tied to outcomes, and the ability to kind of divvy up the patients amongst those who are impacting those outcomes is critical in all kinds of settings of care. So the 4-cut method, again, it's an American Academy of Family Physicians concept, and we've provided the link to their work. The Safety Net Medical Home has a module on empanelment that may also be of value to you. So again, this does kind of trend very primary care, or I guess behavioral health care, given its origin, but certainly you could replace visits with, encounters or surgeries or whatever kind of care model you're in. And basically what the 4-cut method says is that if the patient has only been seen by one provider and one provider only, then that's obviously the assignment. If the patient's been seen by more than one provider, but tends to be seen most often by one provider, then it would go to that. They would be impaneled to that provider, and that's the first and second cuts, if you will. That's like the 4-cut method. If the patient has been seen by multiple providers the same number of times, it's usually assigned to the provider who has performed the most recent kind of comprehensive service, and the remaining patients are assigned to the provider that they saw. If they have not had kind of that comprehensive exam, they're assigned to just the very last provider they saw for any service whatsoever. The reason you will not end up with perfect assignments under the 4-cut method, but what it does is it gives you a starting point from which you can then work, and it can be, as you can see, it can be implemented in an afternoon. It's not something that takes 6 months to get assigned. You can also then immediately begin working to optimize based on the assignment that you have now made. There's a fairness issue. Some providers may say, well, this isn't fair. I ended up with more sick patients. At its starting point, it is what it is, but you will have to kind of modify and adjust from there. The fourth process that is supported by data and technology in patient attribution is targeted patient outreach. This is the idea that under value-based contracts, you will typically require to engage with all attributed patients. You will be highly incentivized to reach patients who are not proactively seeking care within your organization. Maybe they've seen you once over the last 3 years. That's how they got attributed to you. Now your job is to keep them healthy, and you have very limited ability to do so if you do not, as I said earlier, set eyes on these people for extended periods of time. So how do we get them activated and engaged? And this really does start the transition to the patient activation concept, which we'll explore briefly today, and then in 2 weeks we'll do a more deep dive on. This is where everything's kind of starting to come together, but what you really need is you need a risk-adjusted prioritized report of your patients, which, and I probably should say it directly on the side, includes things like what are their care gaps, what are their diseases, what are the challenges that they're facing, what is the last known self-directed treatment plan that they've developed for their condition. If you can get things like recent hospitalizations and emergency department utilization, and sorry, folks, I don't know what's causing that. Oh, there it goes. Okay. So this is really, again, where things start to come into real focus on how this impacts your ability to operate under value-based reimbursement models. There are, again, a variety. Are you able to?
No, I'm not able to because I'm not sure who's doing that.
Okay. If someone's putting us on hold, we're getting a nice hold music. So if you could just mute if you have to do something, that would be helpful. The targeted patient outreach, there are, again, multiple options. In some models, there's a dedicated care management team that performs all outreach. That's kind of a centralized model. In other models, of course, those folks are assigned or embedded directly within the care team and within the clinical setting. In some models, different teams interact with new patients versus established patients. So you might have an advanced team that works exclusively with the patients that pop onto an attributed but not seen report until they're seen, and then they transition to a care manager, essentially, that is embedded within the care team. All patients, in some models, all patients are inside the care team. In some models, all patients are assigned to a care team, whether they have been seen before or not, based on caseload. And then the care teams themselves, so this is the embedded option, then the care teams themselves are responsible for outreach. So you're asking a care team to not just manage the patients that are actively coming into the clinical facility, but also those patients that have been assigned to them. Oops. Again, we are starting now what's going to be the transition into the second big topic of this session, which is activation. And next, the session in 2 weeks is really going to focus on patient communication, and which is critical essentially to the activation process. But we wanted to talk a little bit about different types of outreach. So, of course, many of these are familiar to us. The well patient evidence-based care. So an annual push to get all patients over 65 to get a flu shot and Pneumovax is an example. The chronic disease follow-up, again, something we've probably all been spending a lot of time the last couple of years working on, which is requesting, for example, patients with diabetes to schedule an appointment when their A1C test is greater than 6 months old. And then there's the procedure reminders, preparation instructions, discharge plan, which could be, text messaging patients to begin their fasting ahead of a colonoscopy, or calling each patient discharged for congestive heart failure every day for 7 days to have them step on a scale and check their weight and make sure that they're not taking on fluids the way that would typically land them back in the hospital. These are, I think, pretty straightforward outreach options or different types of outreach that you'll see. And again, in 2 weeks, we'll get into the best practices or the work around those types of patient communication. The last process is a critical one, and it's the removal from attribution process. Anything you negotiate that is a value-based payment model tied to an attributed population, attributed but not seen population, should have a clear definition of how you remove a patient from your empanelment. Your goal, of course, is not to eliminate them versus outreaching to them, activating them, and treating them. But the model does need to have this option because ultimately there will be patients for valid reasons who do not ever matriculate or expect to matriculate into your practice. So we highly encourage our clients that you, of course, need the attributed population from the payer, as with all steps of this process. But you also need to understand the attribution policy and build into your process the attempts that you've made to engage that patient aligned with that policy such that you can track the work that you're doing to engage those patients. So, for example, a attribution policy, which should be clearly spelled out in a contract, might specifically state that you may remove a patient from your panel upon attempting to reach that patient 5 times by phone and once by certified mail.
Your patience is appreciated. Please hold the line, and we'll be right back with you.
I don't know what's going to do here.
Thank you for holding. We look forward to talking with you soon. Please hold the line and we'll be right back with you.
Hey, Jake.
Yeah, Andy. Not really too sure what we can do right now. I'm gonna try to message.
Okay.
Thank you for holding. We sincerely appreciate your patience. Please stay on the line, and we'll be back in a moment.
AJ, I'm afraid we'll lose people if it's fine, but do you want to just use my conference line so we can continue?
Yeah, we can do that now.
Okay. Bear with me, folks.
Thank you for waiting. Your patience is appreciated. Please hold the line and we'll be right back with you.
Joining conference now.
Hi, folks. We're going to give folks about 2 minutes to get reconnected. Hopefully, we'll get everybody back, and if not, we'll carry on. Sorry for that. I wish we had a better option, but that was the reality of the situation. Hi, folks. Welcome back. We're going to wait another 2 minutes. Quite a bit more to cover, and I apologize again for that distraction. Let's move ahead. So we were talking about the importance of understanding how to remove a patient appropriately from your empanelment or from your attribution, and then having the data systems and reports and tools to support that. And I think I was just talking about the use of, for example, a phone call based and then ultimately mail based process. And you're only going to be successful in removing a truly unwilling to engage in care patient if you are diligent in tracking those efforts. So building that capability out either in your EHR or in your practice management or population health system is kind of a critical administrative step that ultimately will help you attain better results under value-based payment models. So understand the policy. Design your outreach strategies to meet the terms of the policy. This can be somewhat challenging because sometimes you'll find methods that work better than the methods that they've prescribed, so you'll have to kind of balance that. But do you have to contact, for example, a patient every month for 3 months before you can remove them? If that's the case, you'll need to have reports that support that, which means you'll need to have a data system, our second consideration, which is a system of record for documenting your outreach strategy. Is that your EHR? Is that your practice management system? Is that a spreadsheet? Is it a population health tool? Whatever those options might be, make sure that you actually have a clearly identified system for documenting the outreach strategies that you undertake. Keep the primary source documentation. If a certified letter is required, keep that scan that certification sticker right into the EHR system so that you can prove to your health plan that you've done everything in their power, everything that you've been asked under that policy and contract to get folks in. And really then, not only is it, you may still, based on your mission, you may still continue to contact the patient, but at least you can remove them from being a negative score against how you get paid, essentially, to provide care. Keep in mind that on the flip side, certain contracts could have financial penalties if you don't demonstrate the kind of outreach that you're doing. So, for example, if you got paid per member per month for care coordination and the patient continually remained unseen by your practice, they could start taking money away for those patients that were unseen. So it's really kind of important to proactively manage this process. We've provided you, and these are a little small, so you'll be getting the handouts. Actually, I think they're already available for you to download right through the portal here. But we have provided you with a couple of wireframe workflow diagrams, really just kind of as a discussion point around how some of this might work that we'll kind of quickly talk through. This process kind of shows the handoff. The top row, which again is hard to read, is the data analyst role. The middle row is the registration team, and the bottom row is the care team. And this process simply talks about a mapping of how an individual organization, and this is one of our actual clients that developed this, and it explains how that handoff occurs. So the data analyst receives the attribution report, compares to the EHR, and practice management system identified which patients were added and which were dropped. The added patients go to the care team that contacts the patients, performs a screening, and moves to the risk adjustment step because they've now received some information about that patient. Obviously, there's a lot more complexity than how do you actually, how many times do you call, who do you call first? But at a high level, this kind of explains kind of that handoff. The drops get sent to a registration team who outreach to the patient, recheck eligibility. If eligible, re-enroll in insurance. If not eligible, discuss other options for financial payment. I can't underscore how critical this is because many value-based contracts require continuous eligibility and continuous enrollment in that insurance. And we see a lot of organizations end up with far fewer patients and thus far fewer payments simply because the patients at some point in the process lapse in their enrollment on Medicaid. So this was designed in a Medicaid model that that required near continuous enrollment essentially, and they actually had to lobby for 11 months of continuous enrollment in a previous 12, simply because every patient at some point throughout the year was disenrolled if they weren't proactively re-enrolling. This next process talks about kind of the risk model and risk work, and again this this kind of shows another handoff between the registration stream and the data analyst. So if registration is performing some type of phone-based screening, if there's no emergent need then identified in that screening, then they simply pass that data back to the data team that risk adjusts the patient, assigns a risk score, and moves the empanelment process. If there is an emergent need, then the screening team, the registration team, is actually allowed to empanel the patient on the spot. They assign them to the provider with the first available appointment and schedule that appointment, and then the patient is seen without any further delay, if you will. And I didn't advance. So this is the one that talks about how they handle the phone-based screening and how that ultimately results in empanelment or identification of a pressing need and a requirement to get the patient in. And this last process diagram talks about what happens to the patients in that empanelment process. So they start with the data analyst making a assignment to a provider based on a data-driven logic model that says kind of which provider's up next. For low and medium risk patients, though they are transitioned then to the registration team, who places the outbound phone calls to the patient and schedules a first available appointment. For the high risk patient, they split those into two different categories: the mobility impaired, in which they perform an in-home consult, the non-mobility impaired, in which they conduct a phone assessment and schedule an initial visit. But they're trying and they're expanding. They kind of expand and contract this model as they learn its effectiveness. But what they're finding is that this is really helping them steer resources in a very, very positive direction towards the outcomes that they need to meet for this population. I've used the term a couple of times, kind of data-driven logic models, but the idea here is that managing attribution in a value-based environment really is about applying a set of rules and then driving data through those rules to make this as efficient and as automated as possible. So our guidance is you really need to look at the models that you want to drive, do some wire diagramming like I just showed you, and identify what data you need to drive those processes so that those processes can be handled really efficiently. Particularly impactful if you are in a large kind of multi-site environment or you're operating in a network with other providers where the whole network is at risk on the contract. But there's so many players involved in making this model work that if it's not largely driven by data, it's not going to be as efficient and timely as is really necessary. So technology is really kind of essential, and we want to talk about the good, the better, and the best. In good models, we're seeing just a lot of heavy lift around using things like spreadsheets and reporting tools. It's not uncommon to distribute reports, using kind of, I hate to say it, primitive technology like email, and which of course, you want to be sure you're doing so in a secure way, but distributing spreadsheets or databases, testing approaches, it gives you a high level of flexibility. So maybe you don't want to go out and buy a Cadillac population health management system until you really understand the model that you want to drive. So maybe spreadsheets is a good way to get started, or handing out paper reports is a good way to get started. It allows you to test approaches with a high level of flexibility. It can create, though, some pretty big challenges for things like management oversight, privacy and security, and sustainability, and thus may not be as scalable as is necessary to make it work. As we mentioned, a lot of folks are driving a lot of these processes through their electronic health records and practice management systems, doing so with a fair amount of customization. Some systems are better than others at serving kind of as the backbone for a population health management approach. It has been our experience that the safety net, and specifically those in the safety net that are entering into value-based reimbursement models, have really pushed hard on the industry in terms of kind of pushing the envelope and the limits of what these systems are capable of doing out of the box, and thus are requiring some pretty considerable customization. It does require you to consider enrolling patients who have never been seen before. I talked about this earlier, so maybe they're not a patient, but they need a chart in the system. And you're going to want to make sure that that doesn't have a negative impact of impacting other reporting. So if you have to do cost reporting based on the number of unique patients, for example, making sure that if a patient never matriculates, they don't end up messing up some other important statistical or mathematical calculations. But again, we are seeing folks move very heavily in the direction of population health systems or bolt-on modules to their EHRs. These are specifically designed to address the attribution and outcome reporting challenge. May or may not be affiliated with your EHR product. Usually accepts data from a common set of inputs like claims and hospital and EHR and all sorts of data sources. They may be static, meaning you don't actually enter information into them. They just simply scoop it from these sources and present it. So then you would need to go back into your EHR, for example, to enter a telephone call with the patient. Others are more dynamic and will actually serve as a documentation tool for the care coordination effort and work that is required. I won't necessarily get into which style is better. I think there's a lot of individual choice there, but there are ramifications to kind of both of those decisions, both kind of medical legal risk ramifications as well as just efficiency and effectiveness ramifications. Just really quickly, because we are running out of time and I have to introduce your final project. We want to make sure that we cover a little bit of the activation side of the equation today. This is going to be talked in much greater detail in 2 weeks. So, how do we send information to patients? How do we receive information from patients? How do we connect people, and how do we transact business? These are the traditionally thought of tools for technology to support patient activation, so portals and secure messaging, personal health records, mobile phones and text messaging obviously seem to be a platform that even within the safety net are gaining a lot of traction. Increased use of home monitoring devices as those technologies have become cheaper, and the internet has really kind of stepped up its game for the concept of internet connected devices. We now have opportunities for things like scales and blood glucose monitors and blood pressure cuffs and all sorts of things that patients can do in home. And then, of course, the role of online communities, peer networking amongst patients with similar diseases, for example. You're probably familiar with a portal, largely because it's been so deeply embedded in kind of the definition of meaningful use. but of course the ability to kind of securely communicate online and support certain administrative and clinical functions. The personal health record, of course, is a concept that basically allows a patient to gather and maintain their own health information and to help organize information from multiple sources. They may have disease-specific applications like diabetes treatment recommendations based on certain health outcomes. We've kind of seen a little bit of a tailing off of the PHR concept in favor of things more like portals, but certainly some practices have successfully implemented them, and the like. We're going to shift gears. We've only got about 15 minutes, and we got to cover a couple of things. In 2 weeks, we're going to get much, much deeper into patient activation and communication, specifically communication technologies or processes. I do want to introduce you to the final project overview. Before I do, let me just pause really quickly. Again, we threw a lot of information at you, and with the disruption, we kind of moved through things a little quicker than we might normally do so. So I do want to pause very briefly and see if anyone has questions or comments. Not hearing any, I'll just remind you to feel free to chat those in as I kind of wrap up. What we want to do, though, is we want to talk about the group project in 1 month, roughly 1 month, 4 weeks from today. You will be each organization will be reporting back on a starting point for what they would consider to be their patient attribution workflow. So this can be what you do today. This can be what you'd ideally like to do. Our goal is to have you put some thought into, based on what you've learned throughout the 6 weeks with us, how you would see a process in your organization supporting some of the value-based reimbursement goals that we've discussed. We are providing you with a checklist, and you will work within your organization with the folks who have been in attendance to simply go through that checklist and help you identify important questions, clarifications, and resources you will need to document essentially your attribution workflow. We do not want the checklist back. That's for you to use. It's intended to be used as a planning and documentation tool. But it will be used to assist in identifying the important questions, clarifications, and resources. That looks like a repeat. This is what the checklist looks like. You can download it from the middle section of your screen, and it does kind of get to some of the questions that we addressed today, but also in the other sessions. Who's responsible for what parts of the process? What pieces of the process are you currently able to do? What data do you have and not have? And you will then choose one of the attribution processes that we discussed. I believe it's your choice. Did we assign them, Amanda, or are they each individual's choice? I think it's your choice which of these that you'd like to explore, or you may propose a different process that you want to explore in this way, and you will create a very basic 4 or 5, no more than 5, let's say, slide PowerPoint. We have a template for you to do that, so it really should help limit you to a small number of slides. And we don't care if you draw it with a pencil, but drawing essentially a diagram that responds to the process and kind of defines the process. It doesn't have to be fancy. It doesn't have to be Visio, but going back and looking at, because I know they were hard to see in the discussion, but going back and looking at the examples we gave, just map out the process. Who are the people that the information needs to flow between? What does the process look like? What are the breaks in the process? If you can have those back to us by April 12th, we will compile them and assign an order for you guys to report out. You're going to spend about no more than 5 to 8 minutes just talking the group through what you learned as part of that process. So again, we hope that this doesn't feel like too much work. We are going to have a quick check-in with each of you that desires. We prefer everybody check in with us for a half an hour on that. But we understand that you guys are busy. But certainly, if you do have a chance to check in, we'd love to kind of pick your brain on what you're thinking about in terms of where to go with this, as well as provide some guidance. And certainly, we want to make sure that everybody feels like this is a kind of an easy and also rewarding process. Any questions on the assignment? Okay. Then lastly, we do have, and just like in previous sessions, there's a link to a SurveyMonkey survey that will allow you to give us some feedback both on the educational content as well as answer a couple of questions that will just help us guide the conversation going forward. So here are the questions. I think they'll also be included in the follow-up email. I'm sorry, they're actually directly in the survey. That's where you'll find them. It really just helps us kind of improve the educational content and also steer the discussions that we have both with you when we get together individually on the phone as well as in this session. I believe that's everything we have for you. You, as always, have our contact information if you need something from us. And with that, I will turn it back to you folks and see if anyone has any questions or comments. Otherwise, we are free to go about our day. Again, I apologize for the issue with the hold music, but thank you for sticking with us, and I'll turn it to you guys.